So Kim, I'll just introduce you to the other people here. The other person here is Dr. Karpagam. She is in charge of our clinical board education.
Oh, nice.
Hi, Dr. Kim.
Hi.
And she's also
Great words I've heard from Dr. Susan, and we're all eager to hear your talk today.
Thanks.
And then we have our IT person. His name is Mr. Ravi. So if you have any issues at any time, you message me. That's also fine. Or you can also put it on the chat box. That's what you see as AVIT written. Oh, Ravi IT, yeah. Ravi. And Dr. Rakesh is here, whom we met at the other night the morning for you, when we had got together. So that's all of us.
You guys been doing a lot of Zooming?
A lot. So since there's not much work to do now, I think this is basically what's happening all over the world right now. Everyone's on Zoom.
Yeah, it's so true. How's the COVID for you guys right now?
COVID, India's right at the top of the list. We are having close to 95,000. I think the last count was about 95,000 cases yesterday, in a day. In a day, all over India. So the number of cases is huge, but fortunately, it seems as though the virus is not as as bad or as severe. So the death rate is low, luckily.
Oh, that's good. Yeah, we're still getting a lot of cases. California's not doing so well.
Yeah, I know. My brother's in California. Remember, I was staying with him when I was with you.
Yes, that's right.
Yeah, my brother-in-law is there. So yeah, I keep hearing all the news. And basically, our hospitals are kind of getting full, but it's not overflowing right now. But it's okay. I guess our government's opened up fully from 1st of this month. So this month, 1st onwards, our state is completely open. Hospitals running full time. All of us are going full time. Till last month, we were going a few days a week. This month onwards, we are going full time. So
you're doing elective surgery?
Yeah. Elective surgeries we had almost never stopped, except for maybe 3 weeks or something in between, when it was a complete lockdown, when the government actually gave a rule that nobody can move out.
Right.
Yeah, it was only at that time that electives had stopped. So emergencies were of course still going on. But other than that, we were doing whatever electives were coming.
Yeah, I think we were shut down 6 weeks, completely shut.
Oh, okay.
Yeah.
Drew and Alex were really okay. No, as far as the links, because we are also going live on YouTube and live on and live on Facebook at the same time. So, Mr. Ravi, where's he? Karpagam?
Yes, doctor.
I'm just checking, ma'am.
Yeah, everything's ready, doctor.
Your Facebook and YouTube lives are fine?
Yeah, it's live. It's live, ma'am.
It's already live?
No,
Yeah.
no. Only for the banner, only live. Stay tuned. Stay tuned and live.
Uh-huh. So what we are saying right now is not live, right?
Yes.
Okay. So classes are virtual now, Kim, huh?
Yes, our daughter is a senior and she's virtual, and then our son is going to be a junior in college and he's virtual. I think.
Fine. We'll wait for 2 more minutes.
Right.
There we go.
All right. Okay. We'll start now. So very good morning, good afternoon, good evening to everyone who's tuned in from all around the world today. Welcome to the Dr. Agarwal's Clinical Board Education Grand Rounds today. And I am Dr. Susan Jacob. I have the distinct honor and the pleasure to introduce our today's celebrity speaker, Dr. Kimberly Cockerham, who is a very, very well-known and well-respected clinician, surgeon, and doctor who's practicing in United States of America. She and my association with her goes back to 2006 when I had the wonderful opportunity to go to San Francisco where she practices and spend time with her learning orbit and orchiroplasty from her. So this is really a very wonderful moment for me after so many years to actually be able to host her in this meeting and to present to all of you such a wonderful person who's my mentor, my teacher, my friend, and who's also a great surgeon, a terrific woman, an amazing doctor. To see Kim in action, it's really awesome. The way she sees her patients, the way she operates, the way she does surgeries, she makes the most difficult orbitotomies look like, you know, child's play. She's in and out, and the tumor's out with it. So that's Kim. She's an amazing person as well, and that's the best part of it. She's so humble and so approachable. She's just a delight to be. So that's my personal introduction about Kim, but I will also give her professional introduction as well. She is the recipient of the American Academy of Ophthalmology Senior Achievement Award, and she has more than 2 decades of experience investigating wound healing and fibrosis within the context of ophthalmology, which is one of her research interests. She has been the chief of oculoplastics and orbital disease at the Walter Reed Army Medical Center and the University of California, San Francisco, which was also where I trained with her. She has published nearly 100 peer-reviewed articles, papers, and chapters, and co-authored the book Diagnosis and Management of Orbital Disease, which I don't know whether you can see it here, is right here with me. And this is the copy that Kim had gifted to me years ago when I went and learned from her. And here is a wonderful message which she wrote to me right there. And I treasure this book, and I love this book for all that it has taught me. So other than this, she is currently an adjunct clinical associate professor in the Department of Ophthalmology at Stanford University and is a consultant for plastics, orbit, and neuro-ophthalmology at the VA Palo Alto Health System. She's also in private practice, and this is she's located in Central Valley of California for a private practice. Now, more than all this, more than the terrific doctor she's also academically very active. She's the section editor for ophthalmology, surgery, and INET, health advisor and writer for Men's Health, and serves as a reviewer for multidisciplinary journals in print and online. She also serves as a consultant and lecturer for Horizon and Luminous. And Dr. Cockerham's research interests have been focused on mitigating inflammation, fibrosis, and combating ocular cancers. She has been a consultant for 3T Ophthalmics for over a decade, helping with grant acquisition, fundraising, clinical trial design, and oversight. And the company now has 6 open, independent, and orphan drug designation for numerous drugs. Phase 1 clinical trials are open, and she is into a lot of research with regards to this. Dr. Cockerham also has a non-profit foundation, Let's Face It Together, for underinsured and insured patients with autoimmune or post-traumatic ocular and facial alterations. And that just goes to show such a wonderful person she is. It is really an honor, Kim, for me to be able to introduce you and host you and invite you to this wonderful meeting that we have every month. And trust me, I know you're going to just blow up this place and you're going to be awesome. So everyone who's watching, this is Kim Cockerham. She is one of the most amazing persons you'll ever be able to meet. Over to you, Kim.
Hello, everyone. Thank you, Susan, so much. That's for a wonderful introduction. It was such a pleasure to meet you back in 2006, and it's been great to see you become a superstar. So thanks for your introduction, and let's get moving on. Orbitotomies. So as you know, orbital disease includes infections, trauma, different inflammatory conditions, and tumors. Today, I'm going to be talking about the approach to diagnosis and management. So there are many common orbitotomies. I kind of put them into 2 lumps. One is incisional, where you're trying to get either drain something, biopsy, or do a therapeutic injection. And then there's excisional, where we're going to actually take the whole tumor out or remove bone for decompression in thyroid eye disease and other entities. I'm going to go through some pearls and pitfalls, both preoperative, postoperative, and then show you the intraoperative approaches. It's very crucial that patients stop all blood thinners. In the United States, there's a lot of people who are on fish oil, flaxseed, that sort of thing. I also have them stop that so that the patient has the best possible outcome. I want to choose the least invasive approach. I also do cosmetic surgery. So my approaches to the orbit include a very cosmetically appealing approach rather than creating lines of tension. Some people, for instance, do a vertical cut to the upper eyelid, which can give a very bad postoperative outcome from the appearance standpoint. So I try to stay with the incisions that follow the lines of the face. And also you need to know when to do an orbitotomy versus don't do an orbitotomy, because sometimes people who don't approach the orbit too often get confused and go into a dangerous situation where, for instance, the blood flow pattern has been altered. So these are the surgical approaches. As you can see, there's natural lines, relaxation lines to the eyelids and the area around the orbit. So I want to approach either through the skin or through the conjunctiva or through the brow in a way that heals nicely and the patient still looks good postoperatively. The lid crease and brow approach to the anterior orbitotomy can be approached either with or without bone removal. This is a very nice approach. Again, you're utilizing something that heals well, looks cosmetically appropriate, but also allows you to get relatively large tumors out that are either in the bone, adjacent to the bone, periosteum, or intraorbital. The lateral orbitotomy with bone removal is a little more complex. And so for folks who don't do orbitotomies, typically they're going to refer this to an orbital surgeon. But again, you're going to be removing the bone. You're going to be utilizing the relaxation lines to allow the patient to heal in a nice fashion that's not deforming in any way. Let's look at this gentleman. So he's a 49-year-old man who complains of a slowly progressive left eye that's bulging and has redness. He complains of a whooshing sound. Any patient that describes that their eye is pulsing or that they feel like they're hearing something, you need to be extremely cautious because this could be either AVM or it could be a CC fistula. So you want to be very careful not to go in and biopsy these patients. Here's a patient more severe, and you can see the tortuous vessels that are a clue to you that this may be something that you shouldn't do an orbitotomy on. You're going to be getting an imaging study. In the imaging study, whether you do an ultrasound, a CT, or MRI, as shown here, you see the massively enlarged superior ophthalmic vein. This is not something you want to go in and approach. When you see that vein being so dilated, you need to suspect that there's been an alteration so that the artery is flowing into the vein and causing arterialization of that vein. Exploration is therefore contraindicated. Biopsy is not indicated. Orbital AVMs can be treated with gamma knife and other approaches, and cavernous sinus fistula is treated in a team approach with interventional radiology. Let's move to intraoperative. So Lone Star retractors are an excellent retractor system, especially if you're in a private practice setting where you may not have a resident or a fellow and your scrub is not that skilled at holding things. So the Lone Star retractors are actually something that was originally brought to the surgery suite by urology, but very nice because you can move them about and secure them with mosquito clamps. Sinus foams such as Flow Seal and fibrillar, which is made by Surgicel, are excellent for bleeding. And if you run into some oozing, they can actually be left in the incision in the orbit. These, the sinus foams are from the ENT scope of practice, and then the fibrillar I found out from a neurosurgery colleague. Decadron is wonderful to minimize postoperative edema, minimize postoperative nausea and vomiting, and it can also be placed as an injection retrobulbar. There's also adjunct orbital therapeutics, and I'll go over one that I recently used, and that's amphotericin, lyophilized. So let's look at this gentleman. So of course he comes in Friday afternoon, and the ophthalmologist on call is not notified. The patient's admitted to the service, and ophthalmology is not notified till 3 days later. The patient's been on IV vancomycin, and as you can imagine, this abscess has just grown and grown. Abscesses do not respond to IV antibiotics. You need to do an incision and drainage. So here's the imaging on the gentleman, and you can see that he has a massive accumulation of pus. He happened to be a prisoner and had a history of MRSA colonization, and you can see that this is not going to go with IV. You need to go in and do an incision and drainage. So I was able to do a debridement to the orbital apex, again, utilizing the patient's eyelid crease so that postoperatively, this is him post-op day 30, he has an acceptable cosmesis. So you do debridement to the orbital apex. In this case, the medial rectus appeared very abnormal and inflamed. You don't want to debride the medial rectus because you want the patient to be able to retain their motility. But you irrigate with antibiotic, in this case it was vancomycin, and the visual acuity actually improved from light perception to 20/25, despite the fact by the time I saw him, he had an intraocular pressure of 50. So this is a MRSA abscess with cellulitis. This is a 37-year-old diabetic who presented to the emergency room with DKA. He was obtunded, and we're now testing everybody for COVID. He was found to be COVID positive. And when he finally became alert, approximately 3 days into his admission, they noticed that he couldn't open his eye and that his eye movement looked abnormal. So what are we seeing here? The eyelid is lifted, the patient is able to adduct, but pretty much all the other motility is out. So the patient can't look up, so that's a superior division of the cranial nerve 3. The patient can't look in, Again, that's cranial nerve 3. And then the patient can't look out. That's cranial nerve 6. In addition, on down gaze, the patient had lack of intorsion. So this patient has what's known as an orbital apex syndrome, which affected cranial nerve 3, cranial nerve 4, cranial nerve 6, and cranial nerve 2. So anytime you have a diabetic with an orbital apex syndrome, you need to be concerned that this could be something like mucor or one of the very invasive aspergillosis. So what are we seeing here? This is the patient's MRI. And unfortunately, in screen left, you can see the patient already has an intracranial lesion. So this had moved into the brain by the cribriform plate. Here's the patient's orbit. And you can see that there's hyperintensity with some hypointensities along the medial orbital wall. So the question is this an abscess? Is this mucor? Is this inflammation secondary to mucor? As you noted, the patient's eye looked very quiet. So let's look back. Note there's no inflammation. So there's no injection, no chemosis. So with mucor, you'd expect that the patient would have more inflammatory signs if this were a true mucor invasion. So the patient already has intracranial involvement. I spoke with him and his family, and we talked about exoneration, subtotal exoneration versus doing some injection behind the eye, so retrobulbar. The endoscopic debridement went well. ENT went in and did a debridement of the ethmoids and the sphenoid, and this is what they found. So it was an invasive species of mucor, rhizomucosis. And so the patient had orbital apex syndrome, but also had already involved CNS. So the decision was made to use a conservative approach. So I went 2 different ways to approach this patient's orbit. I went through the Lynch incision, as you see it above, and I transected the medial canthal tendon to allow an approach to the orbital apex. In addition, I did a limbal incision so that I could approach the medial rectus. And by going these 2 different directions, I was able to do multiple biopsies and explore. I found no purulence, no necrosis, and was able to put 2 cc's of the liposomal amphotericin behind the eye. And in doing so, was able to treat the mucor. When the biopsies I did, I had the pathologist right there so we could look for them. And they were really, it was difficult to even find the mucor. So there was scant or rare mucor found, but it was mainly just an inflammatory response to the mucor that was invading the sinus. So let's look at this approach. How did I get to the orbital apex? So I went through a Lynch incision. It's very similar to the incision that somebody might do for an external DCR. I transected the medial canthal tendon, and I was able to get way back to the areas of the bone. In this case, I didn't remove bone, but rather that was the area where I took the bipolar and was able to treat the periosteum that was inflamed, that had scant problems with the mucor. Another approach, which would be also cosmetically appropriate, would be the transcaruncular incision. This gives you a wide approach also to the wall of the medial aspect of the orbit. I chose the Lynch incision because this was a community hospital where there was no one there to assist me. With the transcaruncular, you do need an assistant to hold the malleables to give you the kind of view of the posterior orbit that you need. So what are the most common adult orbital diagnoses? Well, there's thyroid eye disease, the most common cause of proptosis. Cavernous hemangioma is the most common benign tumor. Lymphoma is the most common primary malignancy. And then there's metastatic breast carcinoma, which is the most common MET. So this is showing a large cavernous hemangioma. And this is to introduce the medial lateral orbitotomy, which is where you take out the lateral wall, move the eyeball over into the space where the lateral wall used to be, so that you can do an approach either transconjunctival or you can do a Lynch incision. But most commonly with this, since it's intraconal, you're going to go through the transconjunctival. So this is a busy slide, but as you can see, there's a large tumor. A lateral skin incision is performed, the bone is drilled down, and then the eyeball is moved into the position where the bone used to be, so that you can approach a large orbital tumor that's in the intraconal space. Everything's put back together, and again, the patient has a nice cosmetic outcome. What are the most common pediatric orbital disorders? Well, there's orbital cellulitis, hemangioma, lymphangioma, rhabdomyosarcoma, and metastatic neuroblastoma. So let's look at a case of a rhabdomyosarcoma. So this is a 10-year-old boy who presented with proptosis and conjunctival injection, and his imaging study is demonstrated here. So he's a massive tumor behind his eye, but fortunately there's an anterior aspect of it that can be nicely approached through the transconjunctival incision. So here's the young man. You can see that he has some conjunctival injection, but has pretty good motility preoperatively. And here he is post-op day 1. So you can see by going transconjunctivally, you can get a very nice approach to a large tumor and do an incisional biopsy. The patient's pathology was rhabdomyosarcoma, and he was referred for an oncologic workup and then treated with radiation and chemotherapy. So let's talk about the pearls and pitfalls of the orbital infiltrations. So a systemic workup is often needed, whether it be thyroid eye disease, lymphoma, IgG4 disease, or cancers, either primary or metastatic. Let's look. It's a 45-year-old gentleman who presents with sudden proptosis and pain. Is an orbitotomy indicated? Well, how do you decide to biopsy or not biopsy? We see a patient who has conjunctival injection, chemosis, he's got erythema and edema of his upper eyelid. You get the imaging study, you see on this axial MRI that there's diffuse infiltration of multiple tissue planes to include the muscles and the fat. So when do we biopsy? Well, you definitely want to biopsy any patient who has a history of cancer, especially breast or prostate. You need to at least consider that this could be part of that process. If the patient has recurrent disease or there's little or no response to steroids, you definitely should biopsy. If there's no pain, you definitely should think about lymphoma. And then as we showed in that last patient, orbital apex syndrome in a diabetic, you have to always think that it could either be mucor or aspergillosis. No, when you not treat, you could just empirically treat with corticosteroids. So if you have the classic first time ever painful proptosis presentation and the patient has involvement of the muscle, the sclera, the optic nerve sheath, or even the cavernous sinus, you don't necessarily need to biopsy that first time. You can go ahead and place the patient on corticosteroids and see what the clinical response is and look at the imaging carefully. So this is a case of Tolosa-Hunt syndrome. Tolosa-Hunt is just orbital inflammatory syndrome that also involves the cavernous sinus. In some cases, it's cavernous sinus alone, but a lot of cases, it's both the cavernous sinus and the orbital apex. You can do empiric corticosteroids with this patient, but you do need to think that this does include lymphoma in the differential, and so you want to follow the patient carefully. If the imaging does not dissolve, as I call it, get completely better with the steroids, you need to consider biopsying the orbital aspect of this. Treatment of nonspecific orbital inflammation includes both systemic corticosteroids, which would be 1 milligram per kilogram of prednisone, or IV methylprednisolone. Much as we now treat thyroid eye disease much more commonly with IV steroids also can work very much like the Kahali approach to thyroid eye disease in the sense that you treat the patient with IV steroids once a week rather than oral steroids every day. This can have a better side effect profile where patients are more comfortable. Often if a patient is going to have to be on corticosteroids for a prolonged period of time, I'm going to think about using methotrexate as a steroid-sparing agent, and less commonly cyclophosphamide. In some patients, external beam radiation can be helpful. And if there's a mass, like a sclerosing orbital mass, orbital decompression, so removal of the bone so that the abnormal tissues have more space, can in rare cases also be helpful. So let's look at this gentleman.
Kim, I'm just going to interrupt you for just a second, just to tell our audience, please feel free to post your questions on the chat box in both the YouTube and the Facebook Live, and we'll take them later. So please do that. I'm sorry. Go ahead, Kim.
Oh, no problem. Yeah, thanks. So let's look at this. This 75-year-old presents with bilateral lacrimal gland enlargement. The patient is known to have concurrent pulmonary disease as demonstrated on a chest x-ray followed by a CT scan to better characterize it. So an anterior orbitotomy by an eyelid crease is performed, and it's just done unilaterally. You don't have to biopsy both sides. And the pathology is demonstrated here below is chronic inflammation with non-caseating granulomas. And so the diagnosis is sarcoidosis. So if you have a patient, again, that has bilateral disease or it doesn't respond well to steroids as it recurs, just like if you think of uveitis, think of orbital inflammatory syndrome is sort of like the uveitis of the orbit. So if it's recurrent or it doesn't respond in the way it should, or the patient has cancer, you want to definitely go forward with the biopsy. Here's another patient with concurrent sinus disease. Past ocular histories included uveitis, keratitis, scleritis, and anterior orbitotomy is done via an eyelid crease incision. And you find that the patient has vasculitis, granulomatous inflammation, and focal necrosis. This is a case of granulomatosis with polyangiitis, or what we used to call Wegener's granulomatosis. This is going to be a patient you really are going to want to involve rheumatology so that you can get the patient on steroid-sparing agents because they can be resistant to steroids. This is a 60-year-old man, presents with a palpable mass. So there was a mass along the eyebrow that the patient noticed when they were touching their face and, as they washed their face, came to me with this mass that's not just of the eyebrow or subbrow area, but rather extended along the superior aspect of the orbit. So again, an anterior orbitotomy was done by eyelid crease. Lone Star retractors are demonstrated here. So you can see they have little hooks and they can be secured with mosquito clamps, so a clamp of any kind. What's nice, you could do this with like a 4/0 silk suture, but then you've got to move the suture around each time you want to get a different exposure with these. What's nice is they can be moved multiple times and placed however you want. There's a variety of sizes. So this is the smallest size, and it's not sharp, so it doesn't result in any additional trauma. And then this ended up being lymphoma. So this was an orbital lymphoma. Lymphoid tumors need systemic evaluation. So there's definitely a spectrum from reactive follicular lymphoid hyperplasia to lymphoma. The ones that are the least common are the problem ones. So the eyelid is least common, but the eyelid is most commonly associated with systemic disease. So in these cases, I get oncology involved, whether it be an orbit, a conjunctival lymphoma, an eyelid, or all the above. A 66-year-old man presents with painful red eye. As you can see, he has conjunctival injection, and the scleral vessels, which you can appreciate here, after placement of neosynephrine, they're still there. They did not blanch. Then you know that you have scleral vessels. The corneal had fine keratic precipitate inferiorly. The AC had 2+ cells and flare, and there was posterior synechiae. This is all consistent with the chronic inflammatory problem of the eye. And here you can see the imaging study. So this is an axial, coronal, and sagittal CT scan demonstrating an infiltrate that is molding to the globe. And you can see inferiorly, there's a location where you can go in without having to do a large surgery and get a nice piece of the process that's going on. So the anterior orbitotomy was performed by a transconjunctival approach, just like I did for the rhabdomyosarcoma in the child. So it's a very non-invasive, and you're able to get in there without any skin incision. So postoperatively, they often have almost no swelling or bruising. So I took the bulbar palpebral conjunctiva, some orbital fat, biopsy of the inferior rectus muscle, and the frozen sections demonstrated a lymphoid infiltrate. Canalog was placed in the inferior orbit since the patient had significant inflammatory process. And you can see here the histopathology shows you sheets of both plasma cells and lymphocytes. When you send this off for pathology, you're also going to be looking at IgG4 orbital inflammation. Why does you want to distinguish lymphoma from IgG4? Because the postoperative care is going to be different. So when you have an orbital lymphoma, whether it include the conjunctiva or the eyelid, you're going to do external beam radiation. In contrast, when these mixed lymphocyte plasma cells are found to be IgG4 positive, you want to do a systemic workup, and then the patient's treated with prednisone and methotrexate. Why do you want to do a systemic workup? Well, IgG4 has preferential sites in the secretory glands, including the lacrimal gland, the kidney, the lung, and the prostate. But it's also associated with pancreatitis, retroperitoneal fibrosis, cholangitis, and silent adenitis. So a patient with even though they have what look like sheets of lymphocytes, you do want to go forward and look for IgG4 disease, or like we used to do fine needle aspiration, and we just identify the lymphocyte and not do further immunohistochemistry. That's not the case anymore. Now you want to get pieces so that these can be sent on for further assessments. You know exactly what you're dealing with so that your post-operative therapeutics are correct. So this is, first of all, I am a medical advisor for Horizon, so I want to let you know that. But I've been very interested in Teprotumumab. It was first FDA approved in January, and then we went into the COVID vacation, as I call it, where we were out of work for 6 weeks trying to do things in a virtual fashion. Meanwhile, these patients were receiving an infusion. They were getting their one infusion every 3 weeks for a total of 24 weeks or 8 treatments. And this is what resulted. So both of these patients responded very nicely with remodeling of their muscles and their tissues within 24 weeks. What's unusual is that I also noticed that they look better. So if you look at the top picture and then the bottom picture, there's not only improvement in the proptosis, improvement in the pain, so they're not having a glabellar, angry look, but their eyes just look much more like they looked before they had the thyroid eye disease. You've got a reduction in the puffiness, but also the reduction in that subbrow fat area, just giving the patient a much more restored look than I can do even with decompression, eyelid surgeries, Botox, and facial resurfacing. So it's been interesting to see these patients evolve. This is the imaging study of the patient who is on the left. So you can see here on the CT and the coronal, or I should say axial and the coronal CTs, that the medial rectus, let's focus on that, is very enlarged, and the patient has a tight orbital apex. So she had a compressive optic neuropathy with 2100 vision. Post-operatively, you can see the medial rectus is much less large, and you can see, especially on the coronals, that now there's fat space so that the optic nerve at the apex is no longer compressed. So not only did the patient get restoration of their appearance with no surgery whatsoever, but they also had relief of their optic neuropathy, which was very impressive to me. I was surprised that the muscles changed this much, this quickly. So let's do summary. So in summary, preoperatively, it's very important to stop all blood thinners. Blood thinners include, of course, aspirin and the nonsteroidals, but also a lot of patients take supplements that you may not be aware of. So do talk to them about stopping flaxseed, fish oil, that sort of thing. Know when an orbitotomy is not indicated. So if you see a patient who is describing either a whooshing sound or has conjunctival injection that's very tortuous, that goes all the way to the limbus, and or you see an enlarged superior ophthalmic vein, you need to be concerned that there's been alteration in the blood flow, either from a carotid cavernous fistula, a thrombosis, an AVM, any of the above. Choose the least invasive approach, and in my opinion, also the best cosmetically appropriate. You want to make your incisions just like you would make your incision for a cosmetic blepharoplasty. So you can either go transcutaneous, respecting the relaxing lines, or go transconjunctival. And either of these approaches can give you a very nice outcome while you're taking care of the serious cancer or thyroid disease or orbital tumor. Lone Star retractors enhance my view. I use them frequently. I use them for when I'm doing a DCR, when I'm doing a temporary biopsy, when I'm doing an orbitotomy. If I'm doing a transconjunctival cosmetic blepharoplasty, I also use them. They are not sharp. They're very atraumatic to the skin. And as I said, you can move them about so that, let's say you're doing the medial tumor, you can have it directed there. And then if you want to go get a biopsy of the lacrimal gland, you can put it up there. So very nice, not expensive. And thank you to our urologic colleagues. The sinus foams, which come from the ENT folks, and the Surgicel fibrillar can be left in the orbit. So if you have a patient who's having a little bit of oozing, it's very nice. You just take the foam and you fill the orbit in the space that you had, or you can use the fibrillar. Neither one have ever caused a problem with postoperative inflammation. And I've followed patients over many years with the following use of this. In contrast, Surgicel, which has more of a component that doesn't dissolve, should never be left in the orbit. You can use the sinus foams or fibrillar. Decadron should be used to minimize edema. So I use Decadron both from an intravenous standpoint. Typically, I'm going to do somewhere around 10 to 12 milligrams of IV Decadron at the beginning of a case. And then in cases where there's inflammation, I'll either use Decadron or Kenalog behind the eye to minimize postoperative swelling and or to treat the inflammatory process. Amphotericin can be utilized to avoid exoneration in patients with aspergillosis or mucor, and it's based on a UCSF protocol. It was 35 milligrams per mil, used 2 to 3 cc's. You can either then leave in a drain and continue daily treatment with that same dosing for 3 days or so, or you can do retrobulbar injections. So without even doing an orbitotomy in a patient who's unstable and you're certain what the diagnosis is, you can just put a retrobulbar, just like you would do a retrobulbar injection, same needle, same syringe. And then in conclusion, you should at least consider a chemical orbital decompression rather than surgery in select patients. So far, I've had 15 patients that I've treated. Many of them have had chronic disease that was not responsive to IV steroids, oral steroids, radiation, and even in some cases, surgical decompression. Yet I'm finding that this Teprotumumab is resulting in a chemical alteration of not only the extraconal but intraconal space. You saw in the CT I showed the muscles actually get smaller by dose 4 or 5 and results in diminished proptosis, improved motility, and overall improvement appearance of the patient. And I think a team approach is really important, both going into it. So like I said, it's going to be a multidisciplinary approach to anything that's got an A in it, somebody arterialized venous, whether it's AVM or CC fistula. Team approach to working with our ENT colleagues and our neurosurgical colleagues and the complex ones that involve multiple spaces. A team approach because it's just fun to work with our colleagues and do the best that we can for the patient. So I want to thank Susan so much. As she was saying, we've known each other for a couple of years, and I had the pleasure of coming to Dr. Agrawal's meeting and getting to see the hospital and going to the OR. And it's, I look forward to the day we can travel again. I'm enjoying the Zoom meetings, but I much prefer to give Susan a big hug. and so I want to thank Susan so much, and Dr. Agrawal and everyone who's on the line for giving me this opportunity to present some of my ideas about Orbit. Jack Hennerdell was my mentor, and he used to jokingly say a day without periorbita is like a day without sunshine. So I love Orbit, and I'm here to answer any questions. Thanks so much. I really appreciate it.
Thank you so much, Kim, for that mind-blowing presentation. It was really, really lovely, and I'm sure everyone who was listening to it enjoyed. At this point, I'd also like to introduce Dr. Balasubramaniam, who is the orbit and oculoplasty surgeon at Dr. Agarwal's Eye Hospital at the main center. And he's also got an extensive experience in this field, and he's also here to discuss as well as to take questions. So, Dr. Bala, please do unmute yourself. Kim, we have a few questions from the audience. One is, any tips for the general ophthalmologist with regards to ocular trauma?
So I think the most important thing with ocular trauma is identifying what the problem is and identifying how acutely you need to approach it. So in the United States, there's been a kind of first all blowout fractures were approached, and now almost no blowout fractures get approached urgently. So if you're referred an orbital approach, an orbital trauma, you want to know, is it a blowout fracture? Blowout fracture plus a lot of other stuff going on. So do they have, also a medial wall? Do they have other parts of their face involved where you need to do a team approach with maxillofacial folks? But the main thing is most orbital trauma does not need to be taken care of in the middle of the night. And often if you do take care of it and you're not sure what you're taking care of, you can cause injury. Most of the time, if there's an open globe, there's not a blowout fracture, but I have been involved in a couple cases where both are going on, and things got mismanaged because, again, in the middle of the night, no one was looking at the imaging study. And so if you're a general ophthalmologist, I would say, look at the study yourself. Even if you don't look at CT scans all the time, do look at it yourself just in case something's been missed. Usually when there's something missed, it's actually pretty obvious. I think it's easier to miss things when you're scrolling through an imaging.
Great. Bala, would you like to also share some comments?
Yeah. Thank you, Dr. Kim, for the wonderful presentation. You took us through a wide gamut of spectrum of disorders involving the orbit. Thank you. I would just like to add that whenever we suspect, like Dr. Kim said, we have to see if there is a open globe injury, one thing, and if there is any foreign body, and if we are getting this one. So if you're not sure of the foreign body, better to get a CT scan rather than an MRI. And although in trauma, generally we prefer a CT scan. And the thing is that, so look for any signs of optic nerve injury also, because what happens is generally in multi-speciality hospitals, they tend to forget the optic nerve. So it's recognized late. So look for optic nerve function. Just a pupillary reaction itself can give a clue to what is the status of the optic nerve. And the other thing is that if you suspect there is any orbital fracture, you tell the patient to avoid blowing the nose so that they don't develop an emphysema. Or even there can be a white-eyed fracture in children, where like it can be absolutely white, the eye can be totally white. So, but in those cases, when there is a trapdoor effect, then we may have to go in for an early intervention. So there can be vomiting, bradycardia and all that. So those signs can give us a clue if there is any entrapment of the muscle.
Great. So basically, just to sum that up from both ends for the audience, if you're having an injury, please look at the globe, look at the optic nerve, look at the orbit in toto, because you might concentrate more on one and forget about the other. So please do see all of them. If you have a pure, if you have just an orbital wall fracture, see which parts are involved. Do you have any, the max pack injuries as well, especially if it's a very bad injury and the patient is comatose or not, and you've been called to the hospital to see him, please do make a point of checking the optic nerve functions, because that might require more immediate management. And also, make sure you also, because I'm also heavily into cornea, if the patient is not conscious, please do make sure that you tape the eyelids. That's important. If it's a proptosis in a blowout fracture, of course, you may not be able to do it. The other thing is you wait generally for 7 to 14 days in between that golden period when you operate for blowout fractures, so the edema is subsided and you get a better view. Most important, ask the patient not to blow, to sneeze, to do any positive Valsalva maneuver, because that's crucial from a general ophthalmologist point of view, and refer fast to a patient, to a orbital surgeon. So Kim, one more question is, here we have is that the indications to intervene in the active phase of thyroid eye disease. What are the surgical indications, I guess, to intervene when you have the thyroid eye disease and it's in an active phase?
So I think the understanding of thyroid eye disease is evolving. We used to think that there was active disease and then there was a cutoff and then you became inactive. And what I'm understanding more and more is there's some patients that have active disease for a decade. There's other patients who have active disease for 6 months. During the active phase of disease, the theory had always been don't do surgery because you can have them have more injection chemosis, more proptosis, because the trauma upregulates the bad cytokine cascade. But it really depends. So I would intervene if the patient had an optic neuropathy, but if the patient had an optic neuropathy and was active, I would do IV steroids as my starting point. And that's 500 milligrams IV methylprednisolone weekly for 5-6 weeks, and then half that dose for another 4 weeks. And then as the patient becomes less active, then I would consider surgical intervention. That said, some patients can't tolerate IV steroids. And so in that kind of patient, I might do like a medial wall decompression or an endoscopic medial wall decompression. Some patients have severe pain that you need to intervene for. And then finally, I get some patients where when they sneeze or they bend over, their eyeballs fall in front of their eyelid and get trapped. So that would be another reason for sure that you'd want to intervene in some way so that the eye doesn't get trapped in front of the eyelids and stretch the optic nerve.
Right. Bala?
Yeah, yeah. I think optic nerve function compromise, I think, is the most common indication. Generally, what we do is we give 1 gram every day for 3 days. And if we feel that still there is no improvement, then we may go in for an endoscopic decompression. So that is the most common indication, like during the active phase. Yeah, lactation. Or maybe if there is a compromise in the cornea also. So if not responding, but so then also we may have to go in for an early surgery.
Great. Yeah. There's also a question about how you would manage thyroid eye disease in the burnt out phase.
So a thyroid eye disease in the burnt out phase, it kind of depends what the problem is. So if the patient has proptosis, it's going to be decompression. If the patient has dysmotility, it's going to be strabismus surgery. If the patient has eyelid retraction, it's going to be eyelid surgery. In some patients, you can do all three in a sequential fashion. It really depends on the need of the patient.
Right. One more question from the audience is, in the COVID setting, I think this is with regards to the patient that you presented, in the presence of orbital abscess, do you wait for the COVID results before proceeding to drainage, or would you drainage immediately? Would you wait for the test result to see if the patient is COVID positive or not, or would you proceed to drainage?
So that's evolved. Back when the first patient was done, the COVID test was taking a long time. The other patient, the COVID test came back in a couple of hours, so we're able to get it very quick. Right now, the way that COVID is being managed is the patients are getting tested in the emergency room before they're admitted in the hospitals that I serve. That's new. For a while, they were only testing the patients that had classic symptoms. We now know that COVID has neurologic manifestations that include stroke. There's also been reported cases of retinal ischemia with cotton wool spots. And then there's a question of what it's doing with other patients where they have visual loss from what looks like giant cell arteritis, and they have elevated SED rate, C-reactive protein, D-dimers. I think that the understanding of COVID is definitely evolving over time, and I think we'll know that there's something more than conjunctivitis, in the long run when we look back at our experiences.
Right. I think also, basically, if the patient is having vision-threatening orbital abscess, you would want to put on a personal protective equipment, and possibly go and drain that abscess if it is really required. Taking all the precautions. There are a huge number of precautions that have been given by various societies, various governments, lots of guidelines available on how to do surgery in a safe manner in case of emergency situations. So if you have an emergency situation, you can follow all those guidelines, take adequate precautions, and then still go ahead and manage that disease. Bala, sorry?
Yeah.
So in the case of that mucor, the endoscopic component of surgery took 3 hours, and it was a negative pressure room. But in order to follow that case, you need to either let the room have 3 rounds of the filtration and or wear the capper or the PAPR, so the respiratory. You don't want to just do it with an N95 ideally, or just put them on 2 different days. You don't want to be in a room where there's been extensive potential aeration of the virus with just an N95.
Yes, so PAPR for the audience is basically a hood which gives you positive pressure into the hood, and so you're breathing only pure oxygen which is under positive pressure. So there's nothing from that operating room that's actually coming in where you're breathing. So as I said, there are lots of guidelines which have been given by various surgeons. So take care of yourself and take care of your patient. Yeah,
and you try to avoid drilling and all that as much as possible to reduce the aerosol formation.
Yes. Yeah. Another question is chemical decompression FDA approved? Kim, what you talked about?
Yes, so Teprotumumab was FDA approved in January. I think it was mid-January. And so it's approved in the United States for thyroid eye disease of all kinds. So not specifically active, not fibrotic, but all comers. And so far the patients, there was a report out of UCSD of a patient who had chronic stable proptosis and underwent the Teprotumumab and showed the same sort of CT findings I had. So apparently it works in patients who are active, but it also works in patients who are chronic and theoretically fibrotic. And when I spoke with Ray Douglas about how that could be, he's not only oculoplastics, but he's endocrinology based with Terry Smith, and they were involved in the development of this. He said the IGF-1 receptor is going to be, so this is an IGF-1 receptor blocker. It's going to be receptive whether the patient's in a chronic phase or an active phase, and that we should really think of the fibroblasts more like we think of hair and skin, and that there's turnover even in the chronic fibrotic state.
Can I ask a question to Dr. Kim? Like, what is the cost involved in the whole treatment of Teprotumumab?
So the treatment is 1 milligram per kilogram. So it depends on the patient's. So a thinner patient would be less, and a bigger patient would be more. I believe it's around 11,000 per injection. That said, several of my patients have been treated under compassionate use because their insurance wouldn't approve it and they had severe disease. The patients that I treated initially were all patients who had no other options. Basically, they had failed everything, and or they were not systemically stable to undergo surgery. With time, it's evolved so that I'm doing some patients where I would normally have put them on IV steroids. With COVID, no one really knows the role of steroids or IV steroids and the virus, and whether it would increase replication in the early stages when you're first developing it. So I have treated now a couple patients where they had not had another therapeutic intervention. That patient I showed you the CT scan of and her before and after, she was someone who had 9 months of activity and had no other therapeutics.
Thank you.
Great. Kim, I have a question. When you see cavernous hemangiomas, we know that cavernous hemangiomas are some of the most wonderful tumors to actually for an orbital surgeon, because they're so lovely to remove, and they're just basically it's a surgeon's delight. Now, is there any particular situation which you would not actually operate? Let's say, for example, I'll give you a particular situation. A cavernous hemangioma that's going very much into the orbital apex. It's actually trying to go through the superior orbital fissure. A lot of pressure on the nerves. Maybe. What would you do? Would you consider that you may have to go more posteriorly? Would you consider EBRT or something also in such cases, or would you go take a surgical approach itself?
So at this point, I think, I don't think I've run into a cavernous hemangioma I wouldn't want to touch. I mean, as you said, they're very nice to take away. And while there can be some adherence at the orbital apex that makes it harder and you have to be extremely careful with your dissection, I use an Alice clamp. I used to use like a cryoprobe, but then many of our ORs didn't have cryoprobes anymore. So I just take a pediatric Alice clamp and utilize that as I use a Q-tip to slowly dissect off the aspect that's at the orbital apex, so that even if there's nerves that are adherent, you can just, with this blunt dissection, just slowly get it out. The bigger the tumor, the more problems the patient is going to have with optic nerve compression or other things. So when patients ask me, I tell them, it's better to get it out before it gets large, but even if it's large, usually it's very approachable. And then if it's not, like if I get in there and I can only debulk it, I send the pathology. And more often than not, if you can't get it out, it ends up being something else, whether it be a hemangiopericytoma or something like that, where you have to deflate it and take pieces.
Right. Bala, you wanted to say something?
Yeah. That's what I concur with Dr. Kim. Like most of the hemangiomas, because they are well encapsulated, so they can be removed.
Yeah.
So unless there is a malignant transformation, like a hemangiopericytoma.
How about lymphangiomas? Would you what would you suggest for them?
So what we have, like suppose if the lid is involved where it's easily accessible, then you can go with a direct injection. And if there is orbital involvement, then what we do is we do ultrasound guided. Under ultrasound guidance, we inject bleomycin nowadays. So that gives us good results. But the thing is that we may have to repeat the injection, and the risk of recurrence is there. So without doing surgery, because removing a lymphangioma completely is also difficult. And so bleomycin injection, that's what we are doing right now.
How about you, Kim? What would your preferred approach be, surgical or injections? I know picibanil is another injection. Do you use bleomycin or picibanil?
Bleomycin. Yeah, no, that's exactly how I do it. Yeah, and in contrast to the cavernous lymphangioma, lymphangioma are, I tell the patient, this is a chronic condition. It may recur. You may be undertreated. I think setting expectations for both the patient and the family, that it's going to be a process over years.
And how do you assess the amount of bleomycin to be injected? Is it based on the volume of the aspirate? If it's a large macrocystic one, how much you aspirate out, blood or fluid, and then according to the amount of. So could you just explain that for our audience?
So you pull out the fluid and you measure how much you have, and then some people do a 1-to-1, others do more. I think a 1-to-1 is probably the most common. So whatever fluid you've removed, you put that fluid back in bleomycin.
So what I do is, like, maybe we don't, maybe around 20% of the volume. That's what we do. Whatever we get. And the maximum dose which we go is about 15 international units. And we calculate about 0.5 international units per kg to a maximum of 15 in a setting.
Would you be more careful if there's an intraconal extension as well? If, like, suppose you have to inject intraconally rather than extraconally. So what?
Oh yeah, definitely. So you can put more volume in anteriorly. If you put that same volume posteriorly, you could have issues, with the volume and compression and transfer of the fluid to the nerves at the apex.
So if there is an extension up to the apex, what we do is we treat the anterior portion first, so that so there is a reduction rather than going in for the posterior portion. So we try to remain more anteriorly if there's an extension up to the apex.
Right.
Because even with our B scan, it's very difficult to get to there. So we generally try to treat the more anterior portion.
Yeah, the posterior ones are very challenging.
Yeah.
Right. So do you do this based on only the imaging studies, or do you try and get a biopsy first? Kim?
Imaging.
Yeah.
Imaging, typical imaging.
Yeah. Okay. So I have one more question from the audience, which is how to avoid ptosis in vertical lid split orbitotomy.
Well, as I introduced, I'm not a big fan of vertical split. I've seen some outcomes that just are not as cosmetically appealing. I think that going through the lid crease is a nicer approach. That said, if you do the lid split and you get so that it doesn't look good, there's a notch, or you get ptosis, you're going to need to go in and treat it just like you would an eyelid laceration. So you're going to reoppose the horizontal aspect of the lid margin, and then make a lid crease incision and go do a levator advancement to get the ptosis to go away. But I think that, the vertical lid split can, especially if you're an infrequent orbital surgeon, can result in poor cosmetic outcome and functional outcome.
All right. So, is there anything you want to add, Bala?
The other thing is that, like in lacrimal gland tumors, so it's not advisable if you suspect a benign tumor like a pleomorphic adenoma. So it's not advisable to go in for a incisional biopsy. So what we do is we go in for an excisional biopsy directly. So based on imaging features, based on the history and all that. So that is one more point I want to add. If it's a
Yeah, I totally agree.
All right. So I think we are very close to the end of our time, and we are also done with all the questions from the audience. I'd like to thank Kim once more for having agreed to come here, spare us some of her time. It's early morning there, I know, and it's nice to have you here with us, Kim. It was lovely to meet you online, and we'll soon catch up in the real world again soon. Thank you so much for having come here, and thank you, Bala, for also having participated and given in your inputs. And Karpagam and the entire clinical board team, thanks for having organized this online educational venture. I think we'll end the session with that. Thanks so much once again.
Thank you.
Thank you, ma'am. Thanks, Dr. Kim, and thanks, Dr. Bala. Thank you, Susan, ma'am. It was lovely having you as a moderator.
Thank you.
And
Thanks,
catching up, seeing you with student and teacher, catching up was really wonderful for us. And thank you for all the lovely tips you gave, ma'am. Thank you.
Thank you, everyone.
Thank you.
Is it cut, Ravi? Is it?